Good morning. It's my pleasure to welcome you to Grand Rounds today. I'm Kaz Nelson, Vice Chair of Education, and I'm very excited to introduce one of our teaching track psychiatrists in our Department of Psychiatry. Many of you know Ellen Buchanan. In fact, she's been in our department since 1996, which makes this her 20th anniversary of being on faculty here at the University of Minnesota. So, yep, it's not totally appropriate to acknowledge that. And many of you might not know about her background, so I'd be delighted to share that with you. She achieved her bachelor's degree at Hope College in Holland, Michigan, went on to complete her medical degree at the University of Illinois College of Medicine in Chicago, Illinois. She completed her psychiatry residency at Michael Reese Hospital in Chicago, Illinois, and then a child and adolescent fellowship in psychiatry, also at Michael Reese Hospital in Chicago, Illinois. She matriculated into a psychoanalytic training program at the Chicago Institute for Psychoanalysis, and then completed a fellowship in addiction psychiatry at the University of Minnesota. So she has this amazing broad-based multi-fellowship training background that she's used to serve our trainees and department over these past 20 years. Dr. Buchanan has served as a consultant for Hazelton Center for Youth and Families and many other locations as well. She's received Teacher of the Year award at least 5 times during her time here, recognizing her excellence in teaching. And she has taught multiple courses in that time, most memorably preparing our residents out of the goodness of her heart over the lunch hour to prepare them for their psychodynamic psychotherapy exams, which are somewhat daunting. And she's also served special roles on committees and in education. Most notably, she gives all of the clinical skills verifications for our first and second year residents, which is essential for their development and getting appropriate feedback, and they always really, really appreciate that. So today she'll be sharing with us about an important topic that she says, well, I already teach the residents this, and I said, yeah, but I need to know about this too. We all have to hear an update on gabapentin and alcohol use disorders. So I was thrilled that she accepted the invitation to present, and I'll turn things over to her now. Welcome, Dr. Buchanan.
Okay, can everybody hear me okay? I kind of have a soft voice. Good? Okay. All right. There are 2 reasons that I chose this topic. One is because we have a lot of pharmacotherapies for alcohol dependence and helping people remain abstinent, which I thought we should review. The second thing is that there was a lot of chatter on the internet about gabapentin and alcohol use disorders, so I thought, well, what's this all about? And I decided to do a literature review, which I did, and so once I did that, I turned it into a Grand Rounds presentation. So I want to share with you what I learned from the literature review. Okay. No disclosures, but I will be discussing off-label medications. Goals and objectives, review FDA-approved medications for alcohol use disorders, including the benefits and limitations. Then I'll review other medication trials for alcohol use disorders. And finally, gabapentin trials in alcohol use disorders, and then talk about some of the research limitations. So just to set the stage, to show you the prevalence of alcohol use, this is from NIAAA at NIH. So this is self-explanatory, but I just wanted to show you what the breakdown was in terms of no risk to highest risk. And then there's also a pie chart that shows almost the same thing. So 28% drink at heavy or at-risk levels to for the risk of alcoholism, liver disease, and other problems. Oh, I was going to go back. Do all of you know the three most important FDA pharmacotherapies for alcohol use and abstinence? See, most of us don't think about this, and we really need to, because they can be very, very helpful for people who want to remain abstinent, including myself. I don't think about it all the time when I really probably should. So the three FDA-approved medications are disulfiram, acamprosate, and naltrexone. Of note, these must be used in conjunction with psychosocial treatments, such as 12-step programs, cognitive behavioral therapy, motivational interviewing. They have to have contact with their recovery peers so they can talk about what struggles they're having and get support. So we'll start out with disulfiram. The way it works is that it inhibits alcohol metabolism, resulting in increased acetaldehyde, and that produces very uncomfortable side effects such as tremor, diaphoresis, unstable blood pressure, severe diarrhea, and vomiting. So it's an adverse reaction to alcohol intake. Now, I had a patient who was on antabuse, and she drank on it anyway and ended up in the emergency room. And I said, what were you thinking? I told you it would make you really sick. She said, well, I just wanted to see if it would work. Anyway, the limitations to disulfiram are if people want to drink, they just stop taking the antabuse and drink, okay? So it's not, you can't control it, essentially. That's why the last one is, it really should be monitored. I'll put it on over here. Some IOP programs have the case managers give it to them. Some of them have their significant other give it to them. I know when I was working at the VA a while back, they had a clinic for antabuse where the nurses would actually give the patients antabuse each day. They'd have to come in and get it. So the limitation to disulfiram is it's contraindicated in comorbid medical conditions, either advanced age, higher risk drinking, severe hypertension, diabetes mellitus, heart disease, history of stroke, peripheral neuropathy, epilepsy, and renal or hepatic insufficiency. And it has no significant effect on alcohol cravings. It's just a deterrent to using alcohol. Sometimes. Going on to naltrexone. Naltrexone is an opiate antagonist at the opioid receptors. Naltrexone blocks the mu receptor, which interrupts the dopamine reward pathway. It has an extinguishing effect, so people can drink on naltrexone, but there's no reward effect. So if they drink alcohol or beer, it's like drinking water. And so after a while, you know, patients kind of give up and say, why should I spend all of my money on alcohol when it's not giving me a high? The limitations, it can cause nausea, vomiting, abdominal pain, headache, fatigue, and elevated liver enzymes. Not in everybody, but in some sensitive individuals. So some people tolerate this fairly well. You should check the liver function tests when you start naltrexone, because naltrexone does cause minor elevations of liver function tests. If the liver function tests go twice above the normal levels, you should really stop naltrexone and try something else. Another problem is it precipitates withdrawal symptoms if any opiates are present in the system. So you always have to check that before you start naltrexone. It has unknown teratogenicity in pregnancy. It does come in an injectable form called Withdrawal, but you should start with oral dosing to make sure they tolerate the medication before you do an injection. And this is the best pharmacotherapy for cravings or continuous relapse. And the dosing is 50 to 100 milligrams a day. So let's talk about acamprosate for a minute. Acamprosate is a glutamate agonist, glutamate is the excitatory neurotransmitter. It attenuates the glutaminergic surge after alcohol cessation, and it also increases GABA neurotransmission, which is the calming neurotransmitter. It's most beneficial for increased anxiety, irritability, physiological dependence, negative family history, late age of onset, and it mitigates relapse severity. Limitations again are that it can, in some individuals, not all, precipitate diarrhea, fatigue, insomnia, pruritus, and it can elevate renal functions. So you should get renal functions prior to starting. The dosing is a problem. You have to take 333 milligrams, 2 tablets, 3 times a day. And a lot of people find that a little bit uncomfortable to do, or they forget their dosage, or they just can't take that much medication. And it really is a matter of patient preference. You know, if they don't like if they don't like taking all those pills, they can try naltrexone. If they get sick on the naltrexone, they can try acamprosate. Okay, so Jonas, in 2014 JAMA article, produced a systematic review and meta-analysis of comparing naltrexone versus acamprosate. The meta-analysis comprised 122 random control trials. Acamprosate, they had 27 studies with about 7,500 subjects, mostly in Europe. And naltrexone, they had 53 studies with about 9,000 subjects that were done mostly in the United States. And the results showed no significant statistical difference between return to any heavy drinking or any drinking at all. So again, his conclusion was that the factors of dosing, frequency, adverse events, and availability of treatment is patient preference and may guide the medication choice. All right, so now we'll start with some of the off-label trials of medication. In 2014, Meeks produced an article in Current Psychiatry. Down here. Topiramate is a glutaminergic antagonist and a GABA agonist. It's recommended for patients who cannot tolerate naltrexone or acamprosate. So this was from a citation from a Lancet Journal 2003. In a randomized controlled trial, they had 150 subjects that were given topiramate 300 milligrams a day. And compared to the placebo, the number of drinking days and number of drinks per day were reduced. Topiramate also reduces mood swings and irritability. Benefits are mostly for abstinence and heavy drinking, and there's a smaller effect for cravings. The limitation is that topiramate has several pretty bad side effects: impaired memory, paresthesias, anorexia, acute or chronic kidney disease, and you have to titrate it up slower than some of the other pharmacotherapies. Okay, so the initial papers on gabapentin, one was done by Fioreri in Clinical Psychiatry, 2007, and he showed that gabapentin potentiates the CNS GABA activity and inhibits glutamate activity, reduces norepinephrine and dopamine release that are found in the reward system. It balances the GABA glutamate dysregulation found during early alcohol abstinence, reduces the risk of alcohol relapse, and protects against both convulsant and anxiogenic effects of alcohol withdrawal. That was a citation by Watson in 1997. So Fioreri's study showed with a randomized control trial, 60 subjects who took gabapentin 600 milligrams a day, and the result was it reduced the number of drinks per day, reduced the number of heavy drinking days, and increased abstinence days. So that was one of the earlier studies. This was one of the best studies that I found. Barbara Mason, with an NIH grant in 2013 in the JAMA journal. She did a randomized control trial with 150 subjects, and they were randomized into either taking gabapentin 800 or 1800 milligrams per day. And the results were that it increased abstinence days and had no heavy drinking. Now, the benefits of this study, she points out, was that it had positive effects on sleep. It's useful if severe hepatic disease is present because gabapentin is excreted in the kidneys, by the kidneys. Limitations: some daytime sedation, dizziness, fatigue, dyspepsia, so it should be used in divided doses. And you should obtain baseline renal function tests, and if they have any renal insufficiency, you should use lower doses. So this is a chart. So figure A is no heavy drinking days, and B is complete abstinence. So you see the gabapentin 1800 did better than gabapentin 900 and did better than placebo. And for the complete abstinence, again, there's really quite a remarkable difference between placebo. It's only, the 900 milligrams is practically twice what the placebo was. And this is another from the same study. The top bar is number of drinks per week. This is the placebo. Doesn't do very well. This is the 900 milligrams of gabapentin, which is somewhat variable. And this is the 1800 milligrams of gabapentin, over a 12-week period was far superior. Okay? So on this side, it was the number of heavy drinking days per week. This is the placebo, did not do very well. This is the 900 milligrams of gabapentin, which did better. And this is the 1800 milligrams, which, as you can see, did a much better job of, even though the outcome was about the same, it was a better overall result in abstinence and reducing drinking days. Okay, so then they thought about, all right, how about if we try and think about what gabapentin plus naltrexone would do? Because naltrexone alone often causes insomnia and mood instability. So this was a study by Anton in the American Journal of Psychiatry, 2011. They had 4 days of abstinence. Over here. One arm was naltrexone alone with 50 subjects at 50 milligrams of naltrexone a day. The second arm was naltrexone 50 milligrams plus gabapentin 1200 milligrams a day with 50 subjects. This was a double placebo, and it ran for 16 weeks. The first 6 weeks was naltrexone plus gabapentin. Then they stopped the gabapentin and just kept them on naltrexone alone. So this is what they saw. Naltrexone and the gabapentin resulted in longer interval to heavy drinking than naltrexone or placebo alone. Fewer drinks per day than naltrexone alone or placebo. Better sleep than naltrexone alone. And when GABA stopped after 6 weeks, the effects did not endure with, now I'll show you a chart on that, did not endure with naltrexone alone or placebo. Limitations in this study was that they had to have a slow titration. Naltrexone, some people start at 25 and then go up to 50. Some people just start at 50. But the gabapentin has to be titrated to avoid side effects from 300 to 1200. Another limitation is impaired memory, paresthesia, anorexia. It's excreted by the kidney and contraindicated for acute or chronic kidney disease. And it should not be, gabapentin should not be used in pregnancy due to the teratogenic effects. I think I have a... Okay, so percent of heavy drinking days, the red is in placebo. The blue is naltrexone alone, and the green is naltrexone and the gabapentin. So the combination of the two produced much better results than either placebo or the naltrexone alone. Now this is percentage of heavy drinking days over here. But you can see down here that after, in the post-gabapentin phase, after 6 weeks, this went up a little bit. With so the effects of the gabapentin did not endure once they stopped the gabapentin. So they did much better during the gabapentin phase. This is drinks per drinking day. Red is the placebo. Got it mixed up. Blue is the placebo. Red is naltrexone alone. And as you can see, the combination of naltrexone and gabapentin was far superior. Not a lot of difference, but a much smoother curve here. Okay. So then I wanted to switch for a minute and talk about using gabapentin for alcohol withdrawal, not just maintenance from drinking. So the main pharmacotherapy that we use for alcohol withdrawal, of course, are benzos. But it has some the benzos have limitations. There's an addictive potential. They can relapse back after being detoxed on benzos. Lack of safety if they use the benzodiazepines with alcohol. There are cognitive impairments from the benzos. Benzos can produce sedation and ataxia, and they are not recommended for maintaining abstinence. So if somebody's alcohol use disorder, in the clinic, you don't want to keep them on benzos. That's contraindicated. The benefits of using the benzos is that the symptoms of insomnia, dysphoria, and craving are less, and benzos have a relatively safe safety profile, positive safety profile. Okay, so then Bonnet did another study, which was published in Alcohol and Alcoholism 2009. It was an open trial with 27 inpatients. The gabapentin doses were 800 to 3,200 milligrams. And this was kind of a different kind of study where they divided it up into early responders and non-responders. So the early responders had a good response in terms of scoring them for alcohol withdrawal. And if there were early responders, they continued to titrate up the alcohol to 3,200 milligrams. With the non-responders, excuse me, there was no change or worse alcohol scores, withdrawal scores, and then they switched them either to clomethazole, which they use in Europe, I guess, or clonazepam. The non-responders had more severe alcohol withdrawal symptoms, and more of them were smokers. And the non-responders had decreased anxiety and depressive symptoms. So this is how they kind of broke it down. Three of the patients or subjects were classified as non-responders and were not included in the study. So just the early responders and the non-responders, totaling 37 subjects, were included in the study. So this is a graph of sort of what they did at baseline. If they were early responders, they increased the gabapentin to 3,200 milligrams. And if they were non-responders, they stopped the gabapentin and switched over to clonazepam. I just thought that was an interesting study to throw in. Okay, the next thing they tried was to compare gabapentin versus lorazepam in alcohol withdrawal. This was done by Merrick in 2009, NIAAA grant, and the aim was to evaluate alcohol use and symptom reduction of gabapentin compared to lorazepam in alcohol withdrawal. It was a double randomized controlled trial, and the conclusion was that gabapentin reduced the symptoms of alcohol withdrawal at the high dose of 1,200 milligrams of gabapentin, reduced alcohol use during withdrawal, and immediate post-acute withdrawal week compared to lorazepam. The lorazepam patients were at higher risk for post-withdrawal alcohol use and more sedation. The gabapentin subjects on 1,200 milligrams had less anxiety, fewer cravings, less daytime sedation, and better work performance. And this just shows some of the demographics, but the most important thing I think here is drinks per day, the gabapentin 900, gabapentin 1,200, and the lorazepam. Okay, another graph here. Let's start with the lorazepam. Looked like this over 12 weeks. And lorazepam at 900 did better than lorazepam. And the gabapentin at 1,200 did the best job, even though it was not really statistically significant down here at the end. But as you can see, the gabapentin at high doses gave them a much better, slower, easier withdrawal. Another chart on the same study is the lorazepam, which kind of went all over the place. I can't really explain this unless the person was having more alcohol withdrawal at that point in time on day 6. But the gabapentin, again, gave a much smoother withdrawal overall, even though, again, it was not statistically significant. Okay. Then they began to look at gabapentin versus chlordiazepoxide for outpatient alcohol detoxification. Study done in 2013 by Stock et al. Now, these were the scales that they used to measure this study: the sleepiness scale, alcohol craving scale, ataxia ratings, the CYAR revised. For both the subjects who were detoxed with gabapentin and chlordiazepoxide. So this study was done in 2013, randomized double-blind trial, 26 subjects, 17 were detoxed with gabapentin, 9 were detoxed with chlordiazepoxide. Gabapentin was used 1,200 milligrams for 3 days, 900 milligrams for 1 day, 600 milligrams for 1 day, and 300 milligrams for 1 day. The chlordiazepoxide, 100 milligrams for 3 days, 75 milligrams for 1 day, 50 milligrams at 1 day, and 25 milligrams for 1 day. And these scales were rated daily. They found no difference in the withdrawal scores day 1 through 4, but on days 5 through 7, the gabapentin scores were a lot lower. And gabapentin scored lower on sedation scales, the Epworth Sleepiness Scale, and reduced alcohol cravings by the PAC scale. So this is just one of the figures that shows the difference between chlordiazepoxide, which would be this, and the gabapentin did much better in terms of symptoms of all these scores here during detox. And this is another, the same study, chlordiazepoxide and gabapentin, which gave better results. What did I do? Uh-oh. These are not syncing right. What am I doing? Yeah, I did. But on this is not syncing with that.
Which one do you want?
Go way down.
New research limitations.
Well, I think there's another slide in there before that. Oh no, that's right. Yeah, that's the one I want.
This one? This one?
I want.
That's what's on there. Is that what you want?
Yeah. Okay. Got it. Okay, so the research limitations on this is because we already have 3 FDA pharmacotherapies to improve abstinence from alcohol. Why should they bother to fund any other studies that are off-label? They won't. So that's why all of these are off-label. The other caveat I wanted to mention is that there is some abuse potential for gabapentin. It's not because gabapentin is addictive or patients develop tolerance to it, but because it does make people less anxious and more mellow, people will ask me for more and more and more gabapentin. And I say, no, this is a reasonable dose for anxiety and maintenance, and we're not going to go up any higher. At the residential treatment center where I consult at the moment, one of the gals was breaking the gabapentin capsules in half and pouring out the powder and snorting it. So, there is that caveat. People will try it on the street to do all kinds of crazy things, but it is not addictive, and it does not develop, you do not develop a tolerance to it. So I want to thank everybody. It's not showing up over there, but I don't know why not, Kaz. We do want to thank all the support people who helped me put this together, and my mentor and colleague, Dr. Specker.
We do have a moment for questions, and we've got these great microphone stands set up for questions. You just have to flip the on button on the top to the top position, flip it up, and we should hear your voice, Dr. Meller. And there is time for other questions and discussion. Thank you.
It seems to be on, doesn't it? Okay, so we're seeing an awful lot of really bad iatrogenic outcomes with benzodiazepine protocols in the intensive care unit. People get so much benzos that they then quit breathing, then they get intubated. We've had one death, and one guy ended up on ECMO, but did just fine. But being on ECMO is not really a great option. So many of us in the consult psychiatry, and I know that Ellen's aware of this, are waiting for the Maldonado and his crew from Stanford to come out with their protocol, which is clonidine plus gabapentin. They'll use gabapentin 800 TID, and they put clonidine patches on both arms, and then a little oral in the beginning. We're using a lot of dexmedetomidine, which is just literally clonidine on steroids. It's literally what it is. And finding that's really been very beneficial. So I think the days of just giving people unending doses of Ativan until they quit breathing, I'm hoping those days are over. I'd like to hear your comments, because I know you and Amer have been messing with gabapentin.
Right. Dr. Amer has started a protocol where if somebody comes in intoxicated to the ER, he starts them on relatively high doses of gabapentin to begin with, and then sees them the next day and adjusts it or adds a benzo if needed. But he starts them out on that protocol in the emergency room.
And that's working?
Yeah.
That's great.
So, Dr. Meller, I have a question for you. You. So, my question is about the mechanism of addition of what your thoughts are of addition of clonidine to the gabapentin versus gabapentin alone.
The idea.
Blood pressure?
What?
Blood pressure?
Pardon me?
Blood pressure?
Yeah, the idea is that when you're in alcohol withdrawal, you're releasing large amounts of catecholamines, norepinephrine, dopamine, whatnot. And that's where blood pressure and your pulse goes up. And you're releasing glutamate, and that's why you have seizures. So you use the gabapentin to counteract the glutamate, use the clonidine to counteract the release of the adrenergic stuff. That's the idea. I don't know if it works.
Steve?
Do you have any thoughts about topiramate, Topamax, which has also been used as a withdrawal agent, but also has pretty good evidence as an anti-craving agent going forward?
I did my slide on topiramate.
I came in late, so if you've already
Here it
covered...
is.
Oh, there, I'm sorry, okay.
What Topamate does work, but it has such bad side effects with cognition and kidney disease, paresthesias, anorexia, and you have to titrate it up slower.
Mm-hmm.
So, some of those are some
Yeah, I
of the
would
raw.
think,
It's
300
not great.
milligrams is a really hefty dose. And this is for maintenance. This isn't for withdrawal.
Correct.
Yeah. Okay.
Correct.
Are people exploring this for withdrawal? Not really, because you have to start it so slow.
Yeah. Yeah. That's the first off-label medication they tried to study. It was topiramate.
Dr. Grand, did you have a comment? I'll invite you.
My comment to Dr. Miller's previous question is that from my understanding, the use of gabapentin has not been studied in anybody that has a history of severe withdrawal. So anybody that has a history of delirium tremens or seizure that has not been tested so far. The trials that have been studied with gabapentin have all been people that have a history of mild to moderate withdrawal and not the severe that lands in the ICU. So that's an unknown.
We don't know because what's coming out is 2 papers on an N of 100. And so they're not allowed to talk about their results because they're in manuscripts being reviewed.
Right.
I don't know the answer.
Right. And that's what I was just saying in terms of like what's currently known is we just don't know the results of that yet, from my understanding. I didn't catch the beginning of the talk. I don't know. Did you speak at all about baclofen?
I looked at baclofen, and the research is not very strong on that. They are saying baclofen is usually more helpful for cocaine withdrawal or abstinence than alcohol. It has been mentioned as one off-label medication.
And I ask because the studies that have been done so far limited it to the current FDA-approved doses for spasticity, so it's only been up to about 75 milligrams. But in Europe, people have been going much higher, so up to about 120 and plus milligrams per day. And there's a recent trial called the BACLED trial that allowed people to go all the way up to 270 milligrams a day. Almost nobody went there. But many people found significant effect titrating to, it was around between like 100 to 120. And so it was kind of an interesting trial of kind of patients self-titrating with physician monitoring. So I think the trials to date in the U.S. have all been kind of capping at the 60 to 80 milligrams per day. So it's interesting when you kind of push that limit a little bit. And the adverse effect profile, lots of people are concerned about seizure induction with either too rapid dose titration either way. And that fact, people found it was actually really quite well tolerated. So it's an interesting medication.
Okay, thanks, Brian.
Dr. Buchanan, first, thank you. I really appreciated the talk. My question was, it looked like the composite data for acamprosate and naltrexone were kind of mixed in general, and a lot of the studies that you showed with gabapentin seem to have a pretty significant positive effect. Where is gabapentin in your treatment algorithm for an outpatient client relative to naltrexone and acamprosate? Do you start there? Do you still start with naltrexone, or?
Well, it kind of depends on what the patient presents as. I mean, if they're presenting alcohol use disorder with a lot of cravings, they would usually start with naltrexone. Okay? If they have a lot of anxiety, I would probably consider gabapentin. If they are kind of chronic relapsers, or they have this kind of dry drunk syndrome, which is irritability, crabbiness, being withdrawn. Camprol is really the one I would go with for that. So it depends on what the clinical presentation is. But just to show you that there are pharmacotherapies that can be used to keep people abstinent.
Thank you.
Go ahead, Brian.
One other question about withdrawal protocols. I know there's been a lot more publication in the tox literature around alcohol withdrawal, and particularly very severe alcohol withdrawal, where there's a big push in a number of circles to try to bring back phenobarbital. I don't know if you read any more about that or what your thoughts are on kind of relatively high early dose for like the first 3 days of phenobarb, and they find it to be a benzo-sparing algorithm, yet with similar, if not better, outcomes in terms of duration of sedation in the ICU and other outcomes.
Well, it's a good question. In my literature review, it was outside the scope of what I was looking for. So I really don't have a good answer for that. But it's a good point.
I'm David Klein, and the clinical faculty. A couple of notes. A comment that appeared in yesterday's New York Times which is a paper that has not always been friendly to us here, told in the Science Times the work of Dr. Mark Willenbring, who I wish were here to discuss his approach to alcoholism, was very much in line of what you've been speaking about. That is, it's a medical disease of the brain, and it is amenable to pharmacological means. But I think we should not forget that there's a lot of other big variables that go into the phenomena of alcoholism and the disorder. And so my question is, do we have some impressions, at least, of long-term use of gabapentin, beyond the times that were limited? And also, the study groups that you had, were they sorted out by any other kind of variables that would, I would think, heavily impact on whether there's a relapse or not? You see, like, is there a good family support system, or is there a job, or is there income, or not? And I would think that would weigh heavily on, regardless of what medicine was used, did they make it or not?
Well, those parameters are certainly crucial to recovery, but those were not mentioned in the review articles. I was narrowing my focus to gabapentin.
I think one thing to keep in mind is that most of our pharmacotherapy maintenance trials are in the context of doing something in terms of treatment for addiction. So they're in some kind of a context rather than prescribing a medication solely, although certainly that there is use of that, but most of the trials are in that context.
We'll end it on that note. Have a nice lunch. Thank you.
Must be used in conjunction with science.
You have been